of the community forum, and then an overview also of the Megabus Act. After that, we will have a presentation on the Contaminants of Concern report, followed by a break. After the break, we will have an update on the K2 surveillance program, and then also an update on the Department of Defense K2. We'll follow that by a question and answer session where we will take a number of live questions from individuals. The individuals, we do ask that you stick to the 3 minutes because of time limitations. After 3 minutes, the speakers will be cut off and we'll move to the answer portion of that specific question. And so I think in general,
your audio is breaking up just a little bit, Elizabeth. So
okay, maybe I'll go off camera and see if that works. So any questions that we do not get to today will be answered and posted on the VA's K2 website. And so we'll follow that by closing remarks. Now I think I will turn it over to Stephanie for the K2 Community Forum.
Hello and welcome. I'm Stephanie Green and the communications contact for VA's Health Outcomes Military Exposures. Next slide, please. You should have received an invitation letter to this forum today. It was mailed in early June. It included the purpose of the forum, presented the opportunity to be able to ask a question during the meeting later on, and let you know where to submit questions on Rally Point. And we also, within the letter, included information about depleted uranium testing, toxic exposure screening, VA's K2 surveillance program, and the airborne hazards and open burn pit registry. And the letter also included additional resources. Next slide, please. So these are, I'm going to let you know about a few online resources where you can find more information. The first is VA's General K2 webpage, and the URL is listed on this slide. And it also links to a community forum specific webpage. And on that page, you can find FAQs. You can find information about the past forum. And that's where we'll keep future information on forums. And also we have past presentations on that page, and you can find information about research. Next slide, please. And then also you can look at Rally Point. There's the link on this page here, and on that page you can also ask questions and participate in discussions. Thank you.
Morning. I'm going to provide an overview of the legislation that is currently in place that governs what DoD and VA are mandated to do with regards to K2. I will note before I start that both the VA and DoD were engaged in discussions and planning for ways to address the health concerns for K2 veterans well before the legislation was enacted, and had the opportunity to provide testimony and discussion with members of Congress, to help fashion this legislation. So, this reflects ongoing efforts between DoD, VA, and our congressional leadership. So the National Defense Authorization Act, is an act that's passed, essentially every year, that provides guidance and mandates to the Department of Defense on a broad range, of activities. In 2021, it included specific information about K2, and the Department of Defense was mandated to conduct an epidemiologic study on the health effects associated with deployment to K2. a contract was set up and has been put into place with the Johns Hopkins University Applied Physics Laboratory to actually conduct a true epidemiologic study.
Dr. Culpepper, it's
Yes. So that is ongoing, and my DoD counterpart, Colonel Badzik, will have more to say about that later in today's discussion, as well as to report on some mortality study findings that were done as part of support of this legislation. Next slide, please. Separately, under the Isaacson-Roe Act of 2020, subsection 210 or 2010 here mandated the VA to engage with our partners at the Agency for Toxic Substance and Disease Registry at CDC to address the health effects of K2. We established a formal relationship to support K2 in March of 2021, and ATSDR took and created the Contaminants of Concern report, and you'll hear more about that in the next presentation, and that has been submitted to Congress earlier this year. As well as ATSDR, as you've seen already, partners with us to support these community forums so that we can keep you updated on the latest findings from our agency's respective work. And we are obligated to provide a final report to Congress in March of 2030 on the status of the health effects that may be associated with deployment to K2. I will describe later, our efforts on the VA side, but we have completed the initial morbidity and all-cause mortality findings, and that will be, the topic of the later discussion. And you can find more about, the legislation as well as the K2 efforts at the website listed there at the bottom of the page. I think that's it for the legislative overview, so I will turn it over to Ms. Scruton right now for the Contaminants of Concern report.
Thank you very much. My name is Karen Scruton, and I'm the section chief for the Exposure Investigations Group at ATSDR, and I'll be providing you with information on the identification of historical potential contaminants of concern, or COCs, at the K2 site. And I'm going to go off camera because I am in the same location as Dr. Irvin, and I want to head off any kind of issues. Next slide, please. So just a little bit of background. The K2 Air Base is in Uzbekistan, also called Camp Stronghold Freedom. It was a Soviet-era air base used for support missions in Afghanistan. The U.S. military operated the base from 2001 to 2005, with just over 15,000 service members deployed during that time. And pursuant to Section 2010 of the Johnny Isaacson and David Rowe, MD Veterans Healthcare and Benefits Improvement Act of 2020, the VA entered into an agreement with ATSDR, and with the intention of ATSDR preparing a report on exposures to at K2 and to assess potential health effects associated with contaminants found at K2. You could next slide, please. So for the data evaluation, environmental samples were taken on the K2 base in the areas noted on the map. ATSDR did extract sampling results from historical documents from 2001 to 2004. Those documents were produced by the Army Center for Health Promotion and Preventative Medicine Europe, or CHPPM. So ATSDR reviewed all the data in the reports. I will discuss the screening process and the contaminants of concern identified from the screening process later in the presentation. But we did review data for organic and inorganic compounds in several media, asbestos in air and water, radiation in air, water, and soil, pesticides in surface wipes, inorganic arsenic in surface wipes, and also sound. Next slide, please. So all data were screened using ATSDR screening levels. Organic and inorganic chemicals were identified as contaminants of concern from the screening process. And I will go into much greater detail about those contaminants that were identified. So organic compounds included volatile and semi-volatile organic compounds, also called VOCs and SVOCs. And inorganic compounds include naturally occurring metals and elements. The term organic just means the compounds contain carbon. So, as I said, the organic and inorganic chemicals are identified as contaminants of concern, and the other items that are listed below are not identified as contaminants of concern for the following reasons. So all asbestos samples were below occupational standards. Radiation data were within the range of background levels in the area. Pesticides were below detection limits in surface wipes. For inorganic arsenic, we have no screening levels in surface wipes, and we did evaluate them in water and soil, but they did not exceed screening levels. And sound was of concern based on flight operations. Next slide, please. So I'd like to just go over the ATSDR screening process and how it differs from the screening process used by the military. So the historical documents where we obtained the data and identified the contaminants of concern, in those original documents, they did identify contaminants of concern based on comparison to military environmental guidelines, or MEGs. And MEGs are used by the military to identify COCs for military personnel and were used to screen that K2 data from in the 2001 to 2004 reports. Now, ATSDR used current screening levels, or SLs, and they're based on protecting residential adults, and therefore they're usually lower than the MEG values. So maximum concentrations identified in each media from the historical documents were compared to ATSDR's health-based screening levels. So the contaminants with maximum concentrations above the screening level were identified as contaminants of concern. But this does not mean that health effects are likely to occur. It just identifies them as contaminants that may be of concern. So additional COCs were identified using the ATSDR screening levels as compared to the MEGs because the screening levels are usually lower values. Next slide, please. So I'm going to walk you through 6 tables that provide the contaminants of concern identified from the screening process and the health effects associated with each of those COCs. So again, the screening process identified COCs as organic and inorganic compounds. The potential health effects listed on these tables are health effects that have been found to be associated with exposure to each of those chemicals. Scientists use information collected from both human and animal studies to identify potential health effects for a chemical. The table notes what kind of study was used to identify the health effect, a human or an animal study, and the animal studies usually mean rats or mice. A chemical can have non-cancer or cancer effects, or both. They're both listed on the table, but the screening levels for cancer effects are usually lower than those for non-cancer. So it's not unusual for a screening level for cancer, but not non-cancer, to be exceeded by the maximum concentration of a contaminant. And I want to emphasize as we go through these tables that even if someone has been exposed to these chemicals, it does not mean they will develop these health effects. Again, the intention of the COC identification was to help the VA inform their K2 surveillance program. Finally, the table indicates with an X which medium the chemical was found in above screening levels, with medium meaning air, water, soil, or gas that has been generated from soil. So on this table, for arsenic, which is an inorganic metal, the maximum level found in water and soil was above the screening level for cancer, but not for non-cancer. For benzene, which is a volatile organic compound, the maximum level in air and soil gas was higher than the screening levels for both non-cancer and cancer effects. And for benzoate-pyrene, which is a semi-volatile organic, it was found to exceed the cancer screening level in air and soil. Next slide, please. So in this slide, the maximum level of bromodichloromethane and chloroform, both VOCs, volatile organic compounds, both of them exceeded the cancer screening levels in water. The maximum level of cadmium and chromium, both inorganic metals, also exceeded non-cancer screening levels in water. The cancer screening level was also exceeded for chromium. And there are several forms of chromium. To be health protective, we listed effects associated with the form that has more health effects. Next slide, please. The maximum level of copper, which is a metal, was found to be greater than the non-cancer screening level in water. For cumene, which is a VOC, volatile organic compound, the maximum level was found to be above the non-cancer screening level in soil gas. And for di-2-ethylhexylphthalate, an SVOC, the maximum level was found to be above both the non-cancer and cancer screening levels in soil. Next slide, please. Ethylbenzene and kerosene are both volatile organic compounds, and their maximum levels were found to exceed the non-cancer screening level in soil gas or air. Methylene chloride is also a VOC, and the maximum level was found to exceed the cancer screening level in air and soil. Lead is a metal and is well known to cause health effects, especially in children. The maximum level was found above the non-cancer screening level in water. Next slide, please. Naphthalene is a semi-volatile organic compound, and the maximum level was found to exceed both the non-cancer and cancer screening levels in air. Particulate matter is basically particulates in air, with the 10 indicating the size of the particles. The maximum level in air was above the non-cancer screening level. And the maximum level for total phosphorus, which is an inorganic element, was found to exceed the non-cancer screening level in water. Next slide, please. So finally, we have tetrachloroethylene, the trimethylbenzenes and xylenes, which are all VOCs. The maximum for tetrachloroethylene was above the cancer screening level in air. The maximum levels of trimethylbenzenes and xylenes were above the non-cancer screening levels in soil gas and or air. Next slide, please. So this table provides a listing of the additional contaminants of concern that resulted from the ATSDR screening, meaning they weren't found as contaminants of concern from the MEG screening, from the military screening. So those are highlighted in yellow. Again, we did expect to see more chemicals identified as chemicals of concern in our analysis because our screening levels are lower than the MEGs or the military values. This table indicates that additional chemicals, VOCs, SVOCs, and inorganics that we identified from our screening but were not identified from the screening done using the MEGs. Two contaminants, propylbenzene and xylenes, were identified from the MEGs, but not from our screening. And that can happen because screening levels do evolve as more information is gathered over time, and the maximum levels just did not exceed our current screening levels. Next slide, please. And we know that uranium and radiation is also of concern at the site. And the military did identify depleted uranium, or DU, in soil in 2001 at the former missile storage site, Site 1, which is outside the military protection berm area. And access to Site 1 was declared off limits for use in 2001. The military measured radiation in soil, air, and wipes within the military protection berm in 2001. And all results were either non-detect or considered to be below background levels. Next slide, please. So there are some limitations and conclusions for this report. ATSDR does recognize that the data at K2 are limited to specific areas of the base and times of testing, and may not fully represent levels of exposure to contaminants by service members at K2. ATSDR identified additional COCs in this report as compared to the K2 documents because the screening levels used by ATSDR were generally lower than the values used in the K2 report, or the MEGs. And the health effects associated with the COCs identified by the ATSDR screening were used by the VA for consideration in the K2 surveillance program, or the K2SP. Next slide, please. Well, thank you for your attention and for attending.
Well, I think because we are well ahead of schedule so far today, that we will proceed with the agenda and then take a break after the next session. So could we have the next slide? Okay, thank you. So today I want to share with you what we're doing with the K2 surveillance program. I know that I introduced this briefly at last year's community forum, so bear with me if some of this seems redundant. Next slide, please. I won't belabor this particular slide, as we just heard from Ms. Scruton, and for those that were at K2, you're well aware of this information. I will note here that there were 3 specific site surveys that were conducted during the K2 occupation to try and ascertain the types of contaminants and that were identified at K2 and what those potential health concerns might be. A number of remediation efforts were taken to try and minimize exposure, and those are listed here by quadrant off areas, marking them as prohibited, fresh soil, and then creating berms to isolate given areas. Next slide, please. So a little bit here on the history from the K2 occupation time frame. In roughly about 2010 or so, there was increasing number of concerns from the K2 community about potential health concerns, and Army Public Health Branch was directed to conduct a study to, begin assessing, K2 related health effects. They initiated that study in 2012 and then reported in the scientific literature in 2015 their findings. that study was limited to only active duty service members with a maximum of only 10 years follow-up, and I think about an average of 7 years. And in that, they compared K2 service members to those that deployed to South Korea in that same time frame. And then they looked in the military health system, the medical record data, to identify disease outcomes. And they looked at a broad range of chronic diseases as well as cancers, in that evaluation. After they did the appropriate statistical adjustments to account for differences between the groups in age, sex, race, rank, branch of service, those kinds of things, the only notable findings were for melanoma and for hemopoietic cancers, which are the lymphomas, leukemias, the blood-borne types of cancers. And there was a higher incidence in the K2 service members compared to the South Korean. The concerns here were that there was only a few cases in each group, and that the statistical estimates of risk were weak and of concern. So at that point, the results were thought to be inconclusive, but still concerning that we would see these types of cancers in a relatively young cohort. And so that kept our awareness and desire to set up and conduct further studies and evaluations, in the K2 community. Next slide, please. So we talked briefly about the legislation earlier. Here we're going to focus on the K2 surveillance program. I had put together a program prior to legislation. When that came forward, we had discussions with our colleagues at ATSDR, and it was agreed upon that VA was best positioned to actually implement, this program. We did get feedback from our colleagues at ATSDR, as well as they convened an external review panel to review the protocol of the K2 surveillance program, and got their endorsement before we actually, began our work. So this program will be set up as a surveillance program, and I'll talk more about that in a moment, but it is designed to evaluate morbidity and mortality outcomes, every couple of years for at least the next 10 plus years, till the time when we have a final report due to Congress, and most likely, well beyond that point. Next slide, please. Okay. So we decided after much discussion and review of the DoD report that really a surveillance approach was the best solution for trying to understand what's going on, with the health from having deployed to K2, and that comes from the fact that this is a relatively young group of individuals. At the time we pulled our initial data 2 years ago, the mean age of the K2 cohort was 53 years old. So in those early years, you don't expect to see a lot of chronic diseases, or a lot of deaths, in a relatively young, healthy, population. So we needed a way to be able to set up and follow this cohort well into the future. Additionally, even for someone that entered K2 in 2001, we only have a maximum of 22 years of follow-up. That really is only an intermediate level follow-up. It's, long latencies are required for many chronic diseases and certainly for most cancers. And so ideally, we would want, close to 30 years or more to make sure, that we do an adequate job of capturing all possible, health outcomes. And then an alternative could have been a survey, but surveys are voluntary. And, depending upon who decides to participate, it may not be representative, of the general population. And it certainly includes fewer numbers, of the population, of concern. And so, for this to be a true, surveillance effort, first, we needed to be able to identify the entire population, what we refer to as the exposure cohort, which would be all of those that ever deployed to Karshi-Khanabad. And we'll talk a little bit more about that in a moment. We also need to be able to identify and create appropriate comparison groups. It is the relative difference, in health with an appropriate comparison groups that helps us understand whether or not a given rate of disease is no different or worse in the K2 group, than that appropriate, comparison group. The third requirement is that we needed to ensure that we get complete capture or nearly complete capture on all of the outcomes, that we are interested in looking at. And in this situation, we're fortunate that, we have both from the DoD side and the VA side, healthcare encounter data beginning in 2000 through the present. Really, this is the first time that we've been able to do that, and so we're able to track diagnosed diseases from 2000 to the present, for nearly every service member and veteran. And then, for it to be a true surveillance, we need to have our methods, that are repeatable and sustainable. And by having and relying upon the medical record data, we clearly are, able to do that. So once we implemented and started down this path, we started work with our DoD colleagues, as well as other groups and agencies, with under the VA umbrella to identify, the K2 cohort. And we also, during that process, once we identified the K2 cohort, then began identifying our comparison groups. And one of those comparison groups were service members, veterans that deployed to OEF during that K2 occupation window, but they never were in K2. And then there was an OEF era comparison group that did not deploy to anywhere in Southwest Asia during the K2 occupation. And so the rationale being for the OEF deployed, we know that K2 was in the Southwest Asia area, and so there would be similarities in the types of exposure. Certainly, burn pits would have been in play, the particulate matter, the noise, those kinds of things. And so having a deployed group compared to the K2, well, we might then be able to single out K2 specific, effects. And then having the OEF era that never deployed to Southwest Asia, then allows us to see, is there really just a Southwest Asia effect, or is it, K2 specific? And we'll talk more about that, again, and give examples, a little bit later. So for our outcomes, again, as I noted, we used the military system, the DoD and the VA healthcare data, and pulled in diagnosed diseases to identify, chronic diseases, the morbidity outcomes. And then we used the mortality data repository, which is a joint DoD, VA, effort where we get information on all veterans and service members from CDC and the National Death Index that provides date and cause of death information from 1979 to the present. So we have 100% capture of mortality data on all those that deployed to K2. And we have morbidity data on roughly 89% of the entire K2 cohort, because not everybody uses VA for their health care. But we did do a quick look early on to see if there were any systematic differences, in those K2 individuals that used VA versus did not, and really did not see any substantial differences that would suggest that there's some systematic bias. So I think that the morbidity outcomes, that we do have are reflective of the larger population. Next slide, please. Okay, so here we talk a little bit about how we went about identifying, the K2 cohort. So our first step was that we got a roster from Central Command that identified, their, 10,400 individuals. And then we also went to, DMDC, which is the Defense Manpower Data Center, which is the group and system that tracks, all deployment information for DoD. That gets fed to the VA Data Identification Record, VADR. And so we looked at both of those, although there's considerable overlap between those data systems for anybody that had a deployment to Uzbekistan. And so that then identified an additional 10,000 folks. We combined those, went through, got rid of the duplicates, which was about 6,000. Were identified that there were about 69 individuals that were civilian contractors, during that. And we took them out, not to ignore them, but VA does not have authority to access their health information, and so we don't have any outcome information on that group. And then, as usual with large data, there were 72 that just had a bad social security numbers, missing digits, or had characters in it, and we're just unable to cross-link that data to identify those individuals. And so that yielded this, master K2 roster of, a little over 15,000. And then we further delved in, to try and identify the amount of time that folks were at K2. And once we started our analytical portions, of the K2 surveillance program, we limited it to those individuals that had at least 29 days of service in K2 or longer, so that we would have some minimum amount of quote unquote exposure time to try and detect, any, health effects. As we learned through this effort, that there were quite a few individuals, that were there for a day or two, kind of a pass through, but that did not actually garrison, at the K2 site, and so we wanted to maximize the chances of being able to detect a health effect if one exists. And the thinking was that if you included folks that were only there for, 1 or 2 or 3 days, that it's unlikely that they would have any appreciable increased health risk. That not confirmed group there, the 2,800, a large number of those were folks for whom we could not confirm the duration at all. And again, we've since learned that many of those folks were special ops or worked in the intelligence community, and their deployment information is classified. and that information never gets included into DMDC or funneled to the VA, website. And so that then yielded the 12,203 that actually, was the sample size for the K2 cohort and the K2 surveillance program. I will note, that there are a number of lines of effort underway, working between VA and DoD to address the deployment information for special ops and the intelligence community. We, have had some very positive meetings, so we are hopeful, that over the ensuing months, that we will get better capture so that we can identify all of those that served, at K2. I will note that, 2 years ago, roughly, when we pulled this roster, so that and identified this roster so that we could pull the data. Since then, we've been able to identify about 1,000 additional K2 veterans using these various data sources, as things have been updated and improved a lot because of PACT Act and taking a closer look at these various data sources. Those additional 1,000 individuals will be folded into the K2 surveillance program before we do our next data pool. And so then they will be part of the surveillance program moving forward. A few characteristics here, on the second bullet is that we have the 12,203 that we have confirmation we're at K2 for a minimum of 29 days. Of that group, 84% overall are enrolled in VA healthcare, and the vast majority, 96% of them, have submitted claims, and most of those that have submitted claims, have been approved. And there you can see that the most common conditions include hearing loss, tinnitus, back, neck, and knee pain, the kinds of things we expect from a combat, physically demanding environment. So a little more about our comparison groups. So we have the OEF deployed, but never to K2, the OEF era that never deployed anywhere in Southwest Asia. And so we selected at a ratio of 5 in the comparison group to 1 in the K2 group for each of the comparison groups. And they were matched on age, sex, race, branch of service, component, and their VA utilization status. We did this matching up front to try and ensure that our groups were comprised of similar veterans, along these different factors, which, based upon prior work, we have found that can influence the disease outcomes. And so we wanted to make sure that we had an even playing ground and that we could then make direct comparisons between the K2 and our comparison groups without having to do any sort of statistical adjustment or concerns, about what a difference in these characteristics, might bring to bear on those associations. Next slide, please. So here I want to just kind of give you an overview of the outcomes that we incorporated into the surveillance program. So most of our outcomes, came from our previous research, and our experience, with the Gulf War and the OEF, OIF, populations. Obviously it includes a lot of respiratory conditions, very specific cancers, and neurologic conditions as well. We also went through and then, based upon the contaminants of concern report that Ms. Scruton described earlier today, and those additional contaminants that they identified, made sure that the health concerns that are associated with those contaminants, that we had those included in the list of outcomes. And then we went to our VBA colleagues and had them provide us a list, of the top 10 disease-specific claims that had been filed amongst K2 veterans. And so it kind of ignored, the hearing loss and the orthopedic, injury things. We were really wanted to know the disease-related kinds of concerns that people were submitting claims, that might then have been associated with exposure to a contaminant of one form or another. So we compiled that list of outcomes, and we'll talk more about those in a moment, but we identified them in the healthcare data based upon diagnosis codes, the International Classification of Disease, Series 9 and 10, which is the way the medical systems, track and document diseases. And so we scanned, the military health system, which includes campus TRICARE, so it covers, retirees, certainly all active duty individuals, and then merged that with the VA healthcare encounter data, which then allowed us to build this kind of longitudinal database of health outcomes from 2000 through 2022. And then once we now had a complete roster, which included the K2 as well as identifiers for each of the comparison groups, we submitted a request to the military or to the mortality data repository and asked for, all the mortality data, that we have on those individuals from 1979 through 2021. As noted, that provides the date of death, cause of death, and contributing cause of death information, on all of those service members and veterans. These data we will, update every year or so, so that we keep this database current. We'll do this at least over the next 10 years, most likely, well beyond that. This way, by having, current data, we'll be able to respond to, rapidly to any emerging health concerns that may come to light. It also positions us, to then, repeat, the morbidity and mortality analyses, that I will describe later on a regular basis. And as well as potentially add in other outcomes as evidence warrants. Next slide, please. Okay, so that kind of gives you an overview of how the surveillance program was designed and some of the rationale for the way that we've done things. I think the advantages are, one, we've identified nearly the entire K2 population and have included them in this. We are able to have two comparison groups that will help us when we look at the findings to determine whether or not an effect in the K2 group is really specific to K2, or is it maybe a more general effect of having served in Southwest Asia. And given the way that we've designed things, we are set up to respond to any emerging health concerns in the future, as well as, we have a sustainable and repeatable method for keeping the K2 surveillance program viable and active, over the next 10 plus years. Okay, so let's move on to some of our initial findings. Next slide, please. So this just shows you some of the population characteristics. As I mentioned earlier, we matched on these characteristics specifically to ensure that each of the groups had a similar distribution, that the age ranges were similar across all three groups. the distribution by race was similar, and so on. And I won't belabor this point, but I think from this you can see that the groups are very, very similar. The advantage that gives us is that this is what we refer to as a more robust way of ensuring that we have proper comparison groups and provides a little more confidence and strength to the associations that we find. Oftentimes we're relegated to doing statistical, analytical based adjustments, which are effective, but not quite as robust as being able to do the matching. Next slide, please. So here is an overview of the neurological outcomes. And before we kind of talk specifically, these are what we refer to as a forest plot. And it provides a great deal of information. And so the data that are presented here are a prevalence ratio. And so basically what it does, the black circles compares the prevalence of a neurologic disease to the prevalence of the neurologic disease and the OEF deployed. And so the circle represents the actual point estimate, and then the lines represents the confidence interval. And for us to be able to conclude that there is an increased prevalence in the K2 compared to the OEF deployed, we would need the point estimate to be above 1 to the right of that vertical line. And we would want the confidence interval, the full confidence interval, to also be, above 1. And so I think what you can see here is that while there are conditions that have a point estimate that's above 1, that the confidence intervals all pass over the 1. And we would not then be able to conclude that there is actually an increased risk for any of the neurologic conditions comparing K2 to the OEF deployed, as well as the K2 versus, the OEF era, with the exception of the next to the bottom there, the post-traumatic headache. But that, again, it's post-traumatic. So these are, from, headaches resulting from TBI, concussions, for injury related issues, as opposed to kind of an exposure disease, related association. So we don't really see anything at this particular point in time amongst the neurologic conditions. So we'll wait just a moment so that others can kind of just scan through these. Okay, could we go to the next slide, please? So here we have same thing for respiratory outcomes, and you can see it's a much larger list, which we would expect, given the environment that K2 fell into. Again, for the vast majority of these, there was no difference in prevalence from amongst the K2 compared to the OEF deployed, or in the K2 compared to the OEF non-deployed or the ERA. One possible exception, is in that other lung category at the top of the chart on the left. That is a large category. It kind of, catches all other respiratory, lung-related conditions. We are taking a deeper dive into that to see if there's something specific, that's driving that, and if so, then we will make that a condition specific and add it to, these charts and tables so that we understand that, and track it, moving forward. And then, chronic pharyngitis, nasopharyngitis, was higher in the K2 compared to the OEF non-deployed, which, is not surprising. That is probably a particulate matter kind of a thing. And actually, that's covered as one of the presumptions, one of the 3 additional respiratory condition presumptions that the Secretary approved a couple of years ago. But again, overall, no real pattern of increased respiratory disease outcomes in the K2 compared to either OEF deployed or OEF non-deployed. Next slide. Now here we have the cancers that we looked at, and you can see the charts, had to be somewhat enlarged because the confidence intervals are very large for a lot of these, and that's because there's only a few cancers in each of these categories in many instances. Not surprising, again, given the young age, and the long latency required for, kind of, the clinical presentation of a cancer. But there are really no cancers that show an increased prevalence in K2 compared to the OEF deployed, the black circles, or in the OEF or in the K2, excuse me, compared to the OEF non-deployed, the orange circles. I will point out that those conditions, those cancers that have a red asterisk, they're the leukemias, the lymphomas, the multiple myelomas, those are all the cancers that were kind of found in the DOD study, the hemopoietic cancers. This is not a perfect matchup, but it's very similar. We don't see that effect here once we've included basically the entire, cohort. We have roughly twice as many of the K2 cohort included in this analysis, and we just don't see that increase, at this time. And I will note that it's also important that these are the same types of cancers that one would expect to see elevated with exposure to radiation. And there have been concerns about whether or not enriched uranium was ever documented, at the K2 site. And these findings, suggest that that was not the case, because exposure to enriched uranium, and ionizing radiation from other sources, typically has a more acute effect, and, with a 22-year follow-up, should that have been the case, we would likely be able to detect such an increase in, these types of cancers. Next slide, please. These outcomes were the ones that we identified from the VBA claims data. These were those that were common amongst K2 veterans, and includes diverticulitis, irritable bowel, chronic fatigue, and hypertension. And while, the point estimates, were elevated above 1, the confidence intervals, crossed that 1, suggesting, that point estimate could fall anywhere in that confidence interval. And we just have no idea, where, so that, we cannot conclude an increased risk one of these conditions, amongst the K2 compared to either the comparison groups. So that kind of gives you an overview of, the morbidity, outcomes that we are tracking. At the present, we're not seeing, any increased risk, in the K2 group, but we will continue to surveil and reanalyze, in the coming years, and that could very well change. Next slide, please. So now we'll talk a little bit more about the mortality, analyses. And for these analyses, it's limited to, all-cause disease-related deaths. We excluded from this particular analysis, accidental deaths, as well as suicides, because those are probably the ones that are least likely associated with exposure to the types of contaminants, we're at K2. We're not ignoring those. The accidental deaths and suicides are incorporated in our cause-specific mortality analyses that are currently underway, and we hope that we will have those finalized, late in the fall, and we'll then be ready to share that, in the scientific literature as well as with, the K2 community once that's completed. So here what we see, is, that red dashed line across the top of the chart kind of shows us the overall survival probability of the three groups. And, they're so similar that they almost overlap with each other, at this point. But overall, there's greater than 97% survivability, or in all of three of these groups. Again, not a surprising finding given, the relatively young age, 53 years old, and relatively healthy group, that describes, the K2 population. So there's no difference then between those three groups, which the plot at the top shows they almost overlap. And the relative risk, which compares the K2 to the OEF deployed. Again, the point estimate was 1.03, so nearly 1, meaning no difference. And the confidence interval, included 1. The relative risk comparing K2 to the OEF, era, the non-deployed, was a little bit below 1, 0.94. Again, the confidence interval include 1. And so basically, that tells us that there's no difference at this point between K2 and the OEF deployed or the OEF era and their mortality risk. In the box there in the kind of the middle of the plot, we also calculate the standardized mortality ratios. And what this does is it compares the mortality rate in a target group, K2, for instance, compared to the general U.S. population of their peers matched on sex, age, and race. And so it's a comparable, comparison groups. Generally speaking, typically, the way that race is programmed is, white versus non-white, which is not the ideal. But that's the way that the data were, our source data were created. And so we have to apply and work within that constraint. The bigger point here is that, what we see is that the standardized mortality ratio for K2 compared to the general population is 0.34, well below 1, suggesting that there is a much lower mortality rate in the K2 compared to the general population. And the confidence interval there in the brackets is also all well below 1, 0.29 to 0.40. And so for this particular analysis, we can conclude that the mortality rate in the K2 group is significantly less than it is in their counterparts in the general U.S. population. Similar findings for the OAF deployed compared to the general population and the OAF era compared to the general population, are significantly lower mortality risk. And I think what this shows us, again, we have a young, healthy group of individuals that deployed to K2, even though, many are now veterans. We're still seeing, that kind of selection bias. You may have heard of the term healthy soldier effect. I think that's, partly in play. And again, at 53 years of age, we would not expect to see a high mortality rate, overall in any general population. Next slide, please. This, is the standardized mortality ratio data, again, kind of plotted on their own, just so that you kind of get a sense, of the magnitude of things. And again, the mortality risk in our K2 surveillance program groups are all substantially lower than what we would expect, from the general population. Next slide, please. So some general conclusions. Okay. So this is the first of many such reports, that, the K2 surveillance program will be conducting to assess the health effects that may be associated with, K2 deployment. Overall, we do not see an increased health risk associated with K2 deployment. The disease prevalence was lower or no different than in the OAF deployed or the OAF era comparison groups, across all the diseases, evaluated, other than traumatic related headaches. The mortality, the disease specific mortality rate was no different, in the K2 group compared to either the OAF deployed or OAF era. And the mortality rates in all three of those groups, were substantially lower than in the general U.S. population. I think these data, provide further evidence that, there's nothing to suggest that enriched uranium was at the K2 site. As noted, the hemopoietic cancers, the lymphoma, leukemias, multiple myelomas, those are the conditions that you would expect to see, with a substantial radiation exposure, kind of the blood, bone marrow types of cancers. And you would expect to see those, within the follow-up period that we have here, because it's a potent exposure and it has, more acute effects. But we do not see any increased risk in the K2 cohort compared to the others. I will also note that to date, VA has completed 334 urine samples, that test for uranium, and it actually tests for depleted uranium as well as enriched uranium. And all of those tests so far, have been negative. So again, there's no specific testing that suggests at least enriched uranium at the K2 site. So at this particular point in time, we do not have any evidence to suggest that K2 deployment is associated with an increased risk of disease or mortality. However, we need, additional assessments, which, the K2 surveillance program will enable us to do before we can reach, firm conclusions about what the potential health effects are from having served at K2. As I've noted, this is a very young group, again, roughly 53 years old. So I would not at this particular point in time expect to see, a large rate of disease and or deaths. And given the long latency that many of those conditions, require before they get detected, we'll need, additional follow-up to make sure that we are doing our due diligence, to capture all possible instances, of disease. And I think what we detect and what we learn in the future, will enable us to make more definitive conclusions about what the potential K2 health effects, are. As well as the fact that with the way that we have things set up now, we are able to detect, anything emerging that may come to light over the next several years. We do partner with our colleagues on the VBA side, the benefit side, and so they run reports on the K2 group so that we see, every 6 months to a year, kind of what the top 25 lists are, so that we can better understand and incorporate those outcomes if we see a particular condition that's receiving a lot of attention, on the claims side. Next slide, please. So a few things that we're working on and some next steps. So I want to reiterate, that K2 veterans, are eligible for all of the PACT Act related presumptions. And many in the letter that you received from us and on our website, there are links to the PACT Act website. There are links to VBA, on how to submit a claim. There are links to VHA, to enroll in VA healthcare if you are not already. So I encourage you to check those links out and to take advantage, of those benefits and services. Additionally, K2 veterans were designated as one of the eligible sites, for enrollment in the Airborne Hazards Open Burn Pit Registry. I will note that it is undergoing a redesign and is anticipated to roll out the implementation of that new formatted registry later this calendar year. And more information will be sent out, as it gets closer to that rollout. I mentioned earlier that we've done 334 uranium tests. All of those, have been negative so far. We are working to finalize, this morbidity report. We will be submitting this to an appropriate scientific journal for peer review. And once that has been reviewed and published, we will take a PDF copy of that and post it on our website for those that are interested that can go and download that for your own reading. Cause-specific mortality analyses are underway. We, are still digging in and working our way through all of those. And as I noted earlier, we plan to kind of get that finalized, sometime in the fall. And once we get to that point, then we will prepare materials to share and then look to schedule another community forum so that we can, inform you of what the findings are from those analyses. The K2 community forum is ongoing, and we will update, findings and other surveillance activities, as well as any other new benefits or services that might come to light. Next slide, please. Okay, so I think at this point, everybody's probably ready for a break. So Elizabeth, I think if we could, say if people could be back to get started by um, in 10 minutes.
Sure. Can you hear me?
Yes.
Yes, we can reconvene at 2:25.
Thank you.
Everyone. Also, while we were on the break, for those individuals who are attendees and have their hands raised, we're providing you links to submit your questions via the Rally Point site. Thank you. Here at 2:25 Eastern time, and so I think I will turn it over for the update on Department of Defense mortality study.
Okay, good afternoon, everybody. My name is Colonel Doug Badzik. I am a preventive medicine physician within the Office of the Secretary of Defense for Health Affairs. And today I am providing an update on the work that has been done with regards to the mortality study on deployers to K2. Next slide, please. So I know that a couple previous briefers have already kind of covered the background on K2 as far as why individuals were there, so I'm not going to belabor that point. But the last bullet on the slide here really is the takeaway here, and that is, in spite of the fact that pre-assessment and site assessments were done, in spite of the hazard remediations that were done as far as restricting access, covering areas with clean fill, etc., that individuals who deployed to K2 actually began to complain as far as adverse health outcomes, and that included that point being championed by both Southcom and CENTCOM. Next slide, please. So, as Dr. Culpepper had previously covered, secondary to some of these concerns that have been raised, a couple previous studies were initiated. First one in 2010 has been discussed by the Army Public Health Command, in which we went and looked at those that deployed to K2 compared to those that were deployed or stationed in Korea during the same time frame. And the study had a lot of challenges, and the results of the study essentially was that there was no more likely for individuals who deployed to K2 than was in Korea to have the outcomes of interest, which were cardiac, pulmonary, mental health, and cancers. But as stated, lots of concerns about that as far as the methodology. So a follow-up study was done in 2015, and as has been discussed, the results of this study were same in the sense that we did see the lower incidence as far as cardiovascular, pulmonary, mental health diagnosis. The overall cancer rate was the same, and that means when we just take all the cancers, lump them in together, look at them as a single group, that was the same. However, there was this weak association that was picked up as far as melanoma and hematopoietic cancers, lymphatic cancers, that required some additional look. And as Dr. Culpepper stated, the weak association was just because there were so few of them, it was really kind of hard to make the proper association. Next slide, please. Thank you. So that kind of brings us to the current effort that is undergoing in the National Defense Authorization Act for 2021, Section 751. Congress stated that the Department of Defense would study exposures to toxic substances of individuals who were at K2 during the time that it was operational, which was defined as October of 2001 through December of 2005. That was also followed by an executive order by former President Trump as he was leaving office on January 19, 2021, with basically the same mandate to study the toxic exposures. Because the two previous studies had been done organically to the Department of Defense, the decision was made that we wanted to get an independent researcher to look at this. And so we actually contracted with one of our federal research partners, Johns Hopkins University Applied Physics Labs, to conduct this larger K2 study. However, the time taken to actually develop the contract with Johns Hopkins Applied Physics Lab, and then also the time required to allow them to get access to the VA medical records, we knew was going to be a bit of time to make that happen. So in the interim, we decided to go and conduct internally a mortality study, kind of as the first step as far as kind of looking at some of the data that we knew we're fairly confident in, and it also gave us time to work with our VA partners as far as developing that agreed upon cohort as individuals who deployed to K2. So that does kind of bring up the, the next question as far as, why would we even, consider doing a mortality study? And really what it comes down to is we were trying to go and develop some very objective standards as far as looking at, what potentially happened from the standpoint of deployment to K2. So one of the first steps in establishing a causal link between a very remote exposure and adverse health outcomes is to look at the most severe, objectively definable outcome. In this case would be death. So when we talk about all-cause mortality, we're talking about death from any cause. And I want to take a moment here really quick too, and I'm not trying to, to demean anybody's, intellect or understanding, but a lot of times we talk about mortality and we talk about morbidity, and sometimes those terms can get confusing. And I know, scientists and doctors like to use big words when we should use smaller ones. But just for everybody's on the same page, so mortality is death, and morbidity is suffering from disease or from a medical condition. And we can move on. Next slide, please. So it's already been covered as far as the K2 mortality for the mortality study population. We worked with the VA to come up with a agreed upon cohort, and it was just over 15,000 service members. And the methodology for us to developing this was we looked at the K2 rosters, we looked at the data from the Defense Manpower Data Center, that's from DoD, and then also as has been discussed from the VA from Vader. And then also when we talk, because we're talking about death, we actually looked at the National Death Index, which is the National Death Repository, to be able to identify cases of service members who had deployed, who had died. In the study, we did exclude a few individuals out of the 15,000. We excluded individuals that were born before 1955 or after 1985. And the reason for that is because there were so relatively few of those that it was introducing, we were afraid it would introduce some odd variants. And so the final cohort that we looked at for this study in particular was around 14,500 or so. And so that was the comparison group. And then what we compared that to was any service member in the Department of Defense who was on active duty, who could have potentially deployed to K2 during that time frame that K2 was operational. So that was, we looked at the cohort deployers of around 14,500 compared to the 3.3 million individuals who could have deployed but didn't. Next slide, please. So this is a little bit of an eye chart here, and I apologize, Lisa, my screen doesn't look, it's coming out like really great, but this is actually a screenshot from the kind of the raw data that we see in the report. And just kind of as a teaser, this report is available now for public release. It's actually up on the DTIC website, although you do have to have a CAT card to access that. But we are actively working to actually get this on a public facing site so all can have access to this, and we expect that to be publicly facing probably in the next 2 to 4 weeks. So looking at the data here, I know that Dr. Culpepper talked a lot as far as confidence intervals, and as he was stating, when we look at confidence intervals, if we see if that confidence interval crosses 1, then it's hard to make any sort of inference as far as whether there's any statistical validity to the finding or not. So in the middle column here, what you're going to see is this is the crude mortality results, and these are just looking at, these are not adjusted for anything. So we're just looking at each individual encounter or category. And so what you'll see here, say for example, we look at sex, we see that the reference is males. And so when we talk about a reference, we are comparing the other groups to that reference. And so we see males as our reference, and that the finding is that our female comparison group comes in at 5.9. It does not cross the 1, so we can say that this is significant. And so we're seeing that in the individuals we looked at, that being female was protective compared to being males. Or the flip of that is that if you were male, you actually had a higher risk. And I can kind of look at the rest of the factors that we looked at. And we looked at age, and not surprisingly, you'll see as individuals get older, they're at a higher risk for death. This is what would be expected. And once again, this is kind of independent of K2 going to K2. This is just looking at the the crude mortality within here. The point that I do want to point out, and that is when we look at the crude mortality, once again, crude being we're not adjusting for any other factor, just looking at the population that went deployed to K2, we see that it came in at a 0.7 risk, and this is compared to individuals who did not deploy. And so that's indicating not only is there no risk for, we would identify a risk as far as on the crude perspective of being deployed at K2, but K2 is actually protective. Now that doesn't make sense, right? I mean that just defies everything. So in order to kind of understand this, we need to go and start looking at the individuals who deployed to K2, and what you'll see is that individuals who are younger are at a reduced risk compared to those that are older. And so when we consider that the vast bulk of individuals who are in the service are in the younger age frames, what we're seeing here is that this is a very concrete reason why it's very important for us to go and look at the other factors that can be confounders, and age being a confounder here, because as I said, it just doesn't make any sense to say that going to K2 is going to prevent people from dying. So if I can draw your attention down to the box that is in red at the very bottom here, we're looking at the crude mortality as we've already discussed as far as at the 0.7, and then we look at the final adjusted mortality. So in the final adjusted mortality, we then go and adjust for an individual's age, and if it adjusts for what service component there are, we adjust for the length that they actually were in K2 and other factors. And what we see at that point, and when we start adjusting, that this notion that K2 is protective just goes away. And so the final adjusted risk mortality comes in at 0.84, and this actually crosses the 1. And so what we can glean from this from a statistical perspective is that there's no indication that deploying to K2 was a risk factor for increased mortality, or it was protective. Next slide, please. So I think we've already covered this slide. I kind of talked through this piece here, and so kind of the results as we put it in the write-up was that that the analysis failed to demonstrate any association between K2 service and increased all-cause mortality or a death by any cause. And next slide, please. So in discussing the results of the study, I really need to make a big foot stomp as far as this first bullet here. And so, even though the results failed to demonstrate this association between K2 deployment and all-cause mortality, it should never be interpreted that these results indicate that there's a lack of evidence that K2 deployers may have increased rates, not have increased rates of adverse health outcomes. And the reason for that is, and I think this has been discussed previously, that many conditions can take years, especially if you may have a subtle exposure that may take years to develop. So this mortality study is only saying that when we look at the K2 deployers compared to all individuals part of the Department of Defense who could have deployed during that time, that we do not see an increased risk of death. But that is not to say that there is not potentially some subtle associations between K2 deployers and some adverse outcomes. And that's one of the reasons why our Johns Hopkins partners are doing this follow-on study. The study certainly had some limitations, although significantly less than our previous studies were done. And the limitations are, as I kind of discussed, that we can't exclude that there are some subtle outcomes that just will take time to pick up on. And then the other big issue is that we just don't really have individual exposure data. We have some, exposure data from point sources that were done at the installation level, but not data as far as what individual service members were exposed to. So this necessitates, the follow-on morbidity study that's being done by K2. And as I kind of said previously, this study, as far as the mortality study, has already been provided to Congress. It's up on the Defense Technical Information Center, or DTIC, and we are working to make this publicly facing so that anybody can access this. Next slide, please. So that concludes as far as my update as far as the mortality study, but I also want to kind of provide just kind of a brief overview as far as where things stand currently as far as with the morbidity study. And once again, this is the one that's being done by Johns Hopkins Applied Physics Lab. So, this one is the one that it was mandated by the National Defense Authorization Act in 2021. And when we contracted with Johns Hopkins, the parameters of the study were to go and, create a retrospective study on health outcomes of service members stationed at K2 and assessing for increased rates of specific cause as opposed to all cause morbidity and mortality. And by as far as specific, we mean as far as the mortality, we're not just saying you died from anything. We're saying you died from X, Y, or Z. You died from a gunshot wound. You died from cancer. You died from chronic heart failure, whatever it may be. And the interesting thing as far as this study goes, and it is very, very distinctly different from the studies that were done in 2010 and 2015, is this study actually combines data from the Department of Defense, which previous studies were only the Department of Defense data, with also VA data. And the other piece is that the previous studies were only looking at administrative type data. And so what I mean by that is anytime you go and see your physician, they're going to go and do a billing code and say, hey, Badzik, he came in for a sore throat or for a sprained ankle, and there's a cool code that they put in there that the insurance companies can bill on that. That doesn't really tell me anything about the medical encounter. That just says, hey, Badzik was diagnosed with ankle sprain or whatever it is. So the difference in this study here is that our Johns Hopkins partners actually looked into the VA medical record. And that was one of the reasons why this took so long to allow them to get access to this. So in addition to the administrative codes, they were actually looking at within the EHR as well. Next slide, please. So this study is still ongoing, and Johns Hopkins has a fair amount of autonomy as far as how they're running this study. But this is just kind of a bit of a snapshot as far as some of the methodology that they're looking at. So when they were looking at the conditions to study, they wanted to kind of focus, not exclusively, but focus on some of the conditions that had been previously brought up in prior K2 studies. And then also when they look at some of the known exposures at K2, what does the literature say as far as conditions that were potentially associated with that? And in addition to that, they also took stakeholders' input into consideration as well. And you see that in the far right-hand column, you'll see these are the stakeholders concerned. And I think what's significant here is that a couple of conditions, pancreatic cancer and multiple myeloma, didn't particularly come out in the literature review. It wasn't brought up in the prior K2 studies, but because of the concerns from the stakeholders, these were actually considered, are being considered also as far as conditions about outcomes for selection. Next slide, please. So this is my final slide here, and this kind of just gives you all kind of a timeline as far as where things stand right now. This has been going on for a while. It was initiated in 2021 in the fall, but it did take us about a year to actually finally get access needed for the Johns Hopkins team to actually access the records. So currently, right now, they have completed designing their study. They've completed acquiring all the needed data, and they're actually in the process of analyzing the data and kind of concurrently developing the report. So we expect for this report to be released to Congress kind of late this year, late calendar 2024, and then upon release to Congress, it will be released to the public thereafter. And that concludes my update on the DoD's work as far as the K2 mortality morbidity study, and I'll turn it back over to the moderator.
Great, thank you. We will now move into the question and answer session. So we have several individuals who will present their comments or questions. You will have 3 minutes. After the 3 minutes, they'll be muted for time consideration. So when I call your name, if you could please come off of mute and ask your question. Responses to each of these questions will be presented. And for the questions that we were not able to get to today, those responses will be posted to the VA K2 website. And so first we have Mr. Thomas Chase, and apologies for any mispronunciation.
Yeah, hi. My name's Thomas Travis, and I recently found that the DoD had my time in K2 was missing, and I'm now going through this slide presentation. It seems that maybe veterans could be put in wrong categories that they shouldn't have been placed in. I know I've been dealing with a lot of health problems, and it seems like it's hard to get the Veterans Benefit Administration to acknowledge veterans who served in K2, even with the presumptives. So I'm not too sure how we could make this process a little more streamlined. That's pretty much my question.
Well,
Thank you. Dr.
thank you for
Culpepper?
your service. Go ahead. Dr. Irving? Were you
I
gonna
was
say?
just turning it over to you.
Okay, thank you. Sorry. So thanks, Mr. Chavez. I will note that we have, over the last several months, increased our engagement with our colleagues on the VBA side. Particularly with the case finding, and identifying all of those that were at K2, and they are well aware of, the additional 1,000 that I mentioned earlier. They are also in the process of creating a standardized reporting template that any VBA adjudicator, analyst, once they enter K2, it goes through and it will provide a more comprehensive, detailed list. So we recognize that this has been an issue, and we are diligently working to try and resolve that. That system should be online, we anticipate, by the end of the summer. So hopefully in the near future, all of you that are working through, a VBA claim, that this particular concern and issue will be minimized.
Dr. Culpepper. And our next question is Mike Bratton.
Yes, ma'am. My name is Michael Bratton. I was a platoon sergeant with, I had a 2nd Platoon, 65th MP Company Airborne. We arrived in K2, Uzbekistan in, what was it, November of 2001, and finally got out of there in August of 2002 after going back and forth, spreading across Afghanistan for several months doing missions and coming back to K2. But I guess I kind of got a different outlook on this. Several of our soldiers from my company have gotten sick, had different cancers. And I personally, I served in Desert Shield, Desert Storm with the 82nd. My unit, 3rd Brigade of the 82nd, got, lack of a better term, slimed with Iraqi chemical munitions that our own engineers blew up. And the Kimisha pit demo, and very little information has come to any of the brigade soldiers from that. On and off over the years, we get a letter from the VA or DOD that we were exposed to the Iraqi chemical munitions that blew up there. So I'm kind of following this closely. I'm glad to see something's coming out, and guys are working diligently to get this out to us. But I learned a lot today about what you're doing to track and reach. I'm kind of more concerned about what you're doing to actually reach out to the veterans, to the service members that are out there, to make sure that they're aware that this is actually going on. DOD does a great job of tracking where our people are and finding them. Matter of fact, my old company commander from 6.5 that was part of the initial invasion, we were the first MPs to go in country. She is getting her 2nd star right now. So, there's a lot of people out there that can help you find. I know find our MP family that was there at the start, and to please reach out. I'm glad you're doing it, but reach out by name and find these individuals, send them letters, reach out and touch them, and let them know what services are out there for them. I beg you. Because one of my individuals right now is going through some cancers, and that leads me into my second question: what advanced cancer screens are out there for the K2 personnel? Because I know it's taken me several years to even get my burn pit interviews done, and nothing has come of all the things I was promised. All the follow-up treatments I was promised. I've never gotten my depleted uranium stuff, even from Desert Storm testing done that I was promised. When I've asked the VA about it, it's kind of fallen on deaf ears. I've had to go through my TRICARE, being a retiree, to try to get additional screenings done. So how do we make these things happen that you're promising?
Okay, thank you, Mr. Bratton. And again, we appreciate your service. And let me see if I can take these in turn. With regards to outreach, we do track and record, postal addresses and email addresses on all of those veterans, that use the VA system or touch the VBA system, and submit a claim. And those are centrally compiled, and that's what we use to send out letters, like for the community forum. It's what was used for contact for the engagement group last week. If somebody in the K2 community is not using the VA, then we technically don't have any way to contact them, right? Because it's when you come to the system, that we're able to collect that information. We do try to post things, through different social media platforms and government, distribution platforms, and information is always displayed on our internal websites, that folks can get to and check on. We encourage, all of you who received a letter to please share that with your K2 comrades that may not have. This is not exclusive. We really want to get, everybody informed and aware of what we're doing with regards to K2. With time, we will continue to update, those mailing lists, and try to keep them as complete as possible. With regards to cancer screening, there's no exposure specific sorts of cancer screenings that are really approved or recommended. If you have a health concern, and certainly, a cancer is a major one, then the types of screening and tests and assessments, are going to be the same regardless of the potential source. So it's important that, you make contact, with your primary care provider and get scheduled, for, the appropriate tests and procedures and those sorts of things. Even with the possibility, of delays, healthcare systems these days are challenged with handling the volume of patients, to be seen. And the VHA is working diligently to try, and improve scheduling and reduce those wait times and get people into specialty care as quickly as possible. With regards to depleted uranium testing, there are ways to do that. If you can contact your environmental health coordinator clinician, they can expedite that. Your primary care should be able to, expedite that. I will have someone reach out to you, Mr. Bratton, to assist, with that and make sure that we can, kind of initiate some contact with folks at your local facility, where the specimen would need to be collected and prepared, and shipped. So look forward to somebody, reaching out and getting in touch with you, in the next week or so, on that.
Okay, yes, sir. And I was just wondering too, like I said, I think the way I originally found out, years ago about that Kimmerisha pit demo in Iraq after Desert Storm was, and my mother and father received a letter. Of course, I'd stayed on active duty service about it from DOD or Department of the Army or something. And so I was just wondering if you guys had any influence with them, because where they could send out to the people like you were tracking that through their records that they knew had come through K2 to say, hey, reach out to the VA and there may be benefits for you if you were at K2 or something along those lines.
Yeah, that's what we've tried to do. We will, work to try and improve upon that. And unfortunately, things that took place in Iraq, haven't.
That was 1990, 91. So, and it was a small, well, I guess it was about 5,000 of us or 6,000 of us in 3rd Brigade of the 82nd versus, the 12,000 you're showing now. So,
and so for those kinds of circumstances, again, that, obviously that was preceded K2 by a decade or so. But there are other presumptions and regulations in place, that govern, the first Gulf War, and those really need to then be discussed, with your VBA representative to make sure that you're fully informed of, what, benefits you're eligible for, under that, those types of exposures.
oh, yes, sir.
Thank you very much.
Thank you, sir. Appreciate your time and your service.
Dr. Culpepper, are the individuals that have joined as panelists to present their questions. I believe the other questions and the responses will be posted to the VA K2 website. Is that correct?
Yes, we have the Rally Point website where any additional questions can be posted, and VHA will be posting responses back within the coming weeks. Apologies if we did not get to your comment or question today, but please use the Rally Point, which is memorializing your questions so that everyone can see them and that everyone can see their responses.
Great, thank you. So I think we can move to the final slide. So thank you again to everyone for participating today. We do plan to continue these meetings annually. And again, the question and answers, both the ones submitted via Rally Point and also the ones for today, will be posted on the VA K2 website. And we do encourage you to check back at the K2 website for future updates as we move forward with the projects. So again, thank you everyone for participating, and we look forward to future engagement.